Good morning, everyone. A special lecture on the anatomy of pelvis, surgical anatomy of pelvis. And we have with us our senior consultant and associate professor of surgical oncology, Dr. Nitin Khunteta. Please.
Thank you, Kapoor sir, for giving me a chance to discuss the surgical anatomy of pelvis. Good morning, everybody. Am I audible to there?
Yes, you are audible.
And the screen is clear, sir?
Yes, also.
So, as we all surgeons have read about surgical anatomy of pelvis, and I want to just refresh it again here, and what new has come in surgical anatomy, the new concepts. So, I'll start my presentation now. So as we know, the pelvis starts from the pelvic brim and goes down to the levator muscle, which has its organs like bladder and the prostate in males and rectum in both male and females, and the uterus and ovaries in females. The pelvic organs are covered with the peritoneal reflection, which is covering the upper and middle rectum, the uterus and part of upper vagina, and the bladder completely. And then the reflection goes anteriorly up to covering the posterior surface of the anterior abdominal wall and posteriorly the posterior abdominal wall. Okay. So this is the female pelvic floor, which shows the muscles of levator ani, which are divided into pubococcygeus muscle, iliococcygeus muscle, and posteriorly the iliococcygeus muscle and the piriform muscle.
Dr. Nitin, sorry to interrupt you.
Yeah.
Yeah, earlier slide was not visible. Now it is visible. Please continue.
नहीं बंद हो गया, फिर बंद हो गया.
There is some interaction in the slide view. Actually, we are seeing only a plain screen. We are not able to view the slides exactly. Avinash?
Yes, Dr. Ajay. Yes, I conveyed the message.
Morning. Yeah, I think there is some hindrance in the slides. You have to see a blank slide on the screen. Just a blank plain slide.
Yes.
Yeah, now it is clear.
इससे आ रहा है.
Speaking from
ऐसे कर लीजिए. आप पूछो, अविनाश पूछो, अब दिख रहा है हमको.
Now it is, yes. Now it is visible.
Please.
ऐसे ही रहने दीजिए. बाद में
1 से 1.5 घंटे बाद. Don't अभी नहीं, बिल्कुल बात नहीं करना, अभी नहीं कर सकते.
छोड़ दो. उनको दिख रहा है.
Okay. Shall we continue? Sir, is it visible now? Clear?
Yes, Dr. Nitin. Now it is clearly visible. Please continue.
Yeah, thank you, sir. So discussing about the pelvic floor here, and pelvic floor muscles are the pubococcygeus muscle, which forms the main part of the diaphragm, pelvic diaphragm, then the iliococcygeus and ischiococcygous, which is seen clearly here, and the piriform is posteriorly. And there the spaces from where the organs goes down from the pelvic floor to the perineum, anteriorly the urethra, the vagina, and the rectum here. In the peritoneal reflection in males are, as shown in this photograph clearly, this blue line is the peritoneal reflection, which is seen, this is covering the bladder, then the pouch of Douglas, which forms here, then the denavinous fascia, which is posterior to the prostate, anterior to the rectum, and then it covers to the middle part of the rectum, goes up and anterolaterally covers the rectum, as seen clearly here. This is the laparoscopic view of the peritoneal cavity, pelvic peritoneal cavity, which is seen here. The peritoneal reflection over the bladder here, which is brilliantly illuminant here, and a catheter balloon in the bladder is seen, and then reflecting posteriorly over the anterior surface of the uterus. And this side view, which shows the posterior part of the pelvic cavity, which is seen, the uterus is seen here, right? And then you can see clearly the uterosacrals, which is covered with the peritoneum and the cul-de-sac that is the pouch of Douglas. This is the laparoscopic view of the posterior part of the pelvic cavity. What is so important here is when we do go for surgery, laparoscopically or open surgery, the most important structure to identify for pelvic surgery is the sacral promontory. Let's go to sacral promontory. Sacral promontory here, which we can palpate when we go for pelvic surgery. And this is the identification mark to identify other structures in the nearby area like at this area, we can see the common iliac is dividing into two, the external iliac and the internal iliac branches. And here the ureter transports from the lateral side to the medial side to end up in the uterine canal and then insert in the bladder. So the sacral promontory is the most important part of the surgical anatomy during surgery. Here it is very clearly seen the sacral promontory has various important structure lying anterior to it. Just above at L4-5, it will be the bifurcation of the aorta, which divides into the right and left common iliac arteries, and posteriorly will be the veins to it. And here you find the superior hypogastric plexus, which is shown clearly on this arrow is showing you superior hypogastric plexus, which divides into the right hypogastric and left hypogastric nerves. You can see clearly the ureter coming from lateral to medial here and then inserting into the bladder here. And here, you can see clearly in the next photograph that the sacral promontory, we find if we go further right on the lateral side, we can see the IC junction. The ileum can be identified here. Adjacent to it will be the appendix, and that acecum and ascending canal will be there. Left to it will be the sigmoid mesentery. Mesentery will be seen clearly, and when we lift the sigmoid column during surgery, you can see the sigmoid mesentery clearly, and the inferior mesenteric artery tracing going down and forming the superior rectal artery and the branch to the sigmoid colon. So that's the importance of sacral promontory during surgery. Now discuss something about the vascular schema of the pelvis, where it is seen clearly that the aorta, which divides into the right and left branches, the common iliacs at the level of L4-5, and this external common iliac divides into the external iliac artery, which goes down and gives only one branch, that is the inferior mesenteric artery, and one more branch in around 25% of patient, it gives down to known as corona mortis. We'll discuss in next slide. And the internal iliac artery, which divides into the anterior trunk and the posterior trunk. You can see here the anterior trunk here, the internal iliac artery giving the anterior trunk and the posterior trunk. Posterior trunk has the iliolumbar artery, which goes up posteriorly, and the lateral sacral and the superior gluteal artery continues here like this. The anterior trunk, which divides, which has its branches. The first is the obliterated umbilical artery, which forms the medial umbilical ligament. Then the obturator nerve, which goes along with the obturator artery, which goes along with the obturator nerve, giving it to superior vesical artery, then middle rectal artery, and posteriorly it goes down, giving to pudendal artery here. So this is the arterial vascular schema that I've shown here. You can see the difference in the male and female pelvis here. The only one branch which comes to the uterine artery comes here, divides as the third branch from the anterior trunk of the internal iliac artery. And these are the different vascular branches which are going in the male pelvis and the female pelvis. And the peripheral branches are the lateral sacral, iliolumbar, and superior inferior gluteal artery, which goes posteriorly. Posterior is going in the great ischemic foramen. From there, it goes into the lower extremity. This is a beautiful photograph which shows clearly the anatomical details, where we can see the trunks, the anterior trunk clearly going anteriorly, forming the external iliac, and this is the inferior epigastric artery, and the posterior trunk giving the anterior division, and the posterior division at which visceral branches are here, and the peripheral branches are seen clearly here. Again, this is the venous vascular schema of the pelvis, where all these arteries are along with, they have their own veins which run along with and opens up the visceral branches, and the peripheral branches opens up in the internal iliac vein, which is a big trunk we can see during surgery, and the external iliac vein joining and posteriorly to the artery, joining to form the common iliac trunk, and then joining to go up into the IVC. Very important to know here about the corona mortis, the crown of death. It is known. Why it is not known crown of death is because this is the vascular anastomosis between the obturator or external iliac artery and the inferior epigastric artery here, which has an anomalous anastomotic connection with the obturator artery. And when we do a pelvic lymph node dissection, the lower boundary is almost up till here. And if we don't identify this structure, the corona mortis, it is known as the prevalence of this corona mortis vascular anomalous is 46%, which is more of venous in 42% and less arterial 25%. During obturator fossa lymph node dissection or any surgery in space of Retzius that we do for sling for the bladder, or when we do an inguinal surgery for inguinal hernia, we really have to identify this structure and safeguard it, because any damage to this structure will lead to torrential bleeding, and it cannot be seen. It is well, hidden behind the structures here, the inguinal ligament here. So it's very important for us to identify this structure and safeguard it during this surgery, inguinal hernia surgery here. This is the lymphatic schema, which shows the different organs as well, lymphatics going to the first Echelon nodes along the arterial system, the uterine artery having its first Echelon node at its origin from the same as the rectal, middle rectal, bladder, and that's how the cancer of these organs spread from along with in the lymphatics to these first Echelon nodes, and finally they goes to the anterior trunk lymph nodes and then the common iliac, and then they ascend. As the time goes off in cancer patient, as the tumor grows, it goes to the subaortic and then aortic and para-aortic region. That's how the lymphatic metastasis happens in cancer patients. Now I'm going to discuss about something about the neural schema of the pelvic organs. The neural schema of the pelvic organs, as this photograph clearly shows, that this is the bifurcation of the aorta, where we find the superior hypogastric plexus. Superior hypogastric plexus is mostly a sympathetic system. The other photographs will show you in detail, which gives rise to hypogastric nerves, the right and left hypogastric nerve. And from here down in the sacral area, the S2, 3, mainly S3 and 4, from the sacral vertebra comes the parasympathetic nervous pelvic splanchnic nerves, which join here at the level of the fornices and forms the inferior hypogastric plexus, which give branches to the bladder, to the vagina and cervix, and posterior to the rectum. And the importance of this system we should know is because when we do anterior resection, excentrations, APR, radical hysterectomies, these all neural systems should be saved except the organ we are removing, so that the morbidity of that surgery can be minimized. Again, this shows very clearly here. You can show the autonomic plexuses in the abdomen. This is the celiac plexus ganglion here. This is the intermesenteric plexus. This blue lines are intermesenteric plexus here. And then comes the superior hypogastric plexus, which is formed by the nerves coming from T10 to L2, L3 neural roots. Along with that, then they go down to superior and inferior hypogastric nerves, which combines with the sacral S2, 3, 4 nerves, parasympathetic. This sympathetic forms the inferior hypogastric plexus here. Again, this photograph shows a clear, when you take a photograph during surgery, you find these nerves like yellow structures, fine yellow streaks of structures and minute vessels running on them. And these are the nerves that has to be saved when we do a pelvic radical surgeries in cancer. Clearly shown here, the superior hypogastric plexus, you can see the lateral view, along the inferior hypogastric plexus, and the different organs, like these are branches which are going to the bladder, here the branches going to the cervix, uterus and vagina, and posteriorly rectum and anal canal. Yeah, this photograph shows very clear anatomy here, where we can see the celiac plexus in the upper part, the intermesenteric plexus in the middle part, and just below at the level of inferior mesenteric artery, and the superior hypogastric plexus, which is coming from mainly from the T12 to L1, L2, and N3. These branches from the superior hypogastric plexus is mainly sympathetic here, which give branches to the bladder, prostate, seminal vesicles in males, and the bladder neck here. And down, if we see, these are the branches which specifically form the prostatic plexus, which is posterior to the prostate, which has to be saved during surgeries of the rectum and when we do a radical hysterectomy. Same way in the females, you can see this is the inferior hypogastric plexus area, superior hypogastric plexus, which gives branches and forms the inferior hypogastric plexus. And there is the bladder plexus, vesical plexus known as here, which has multiple nerves running over the bladder, which has to be saved. When we do radical hysterectomy, we cut the nerves here, save these branches, which goes to the bladder, and posteriorly this inferior hypogastric plexus, which is a mixture of sympathetic and parasympathetic fibers, parasympathetic coming mainly from S2, S3 and S4, partly some from S2 also gives, this plexus give branches to the rectum also for proper defecation process. Now I'll discuss something about the pelvic spaces. The peritoneal epithelial lining, which covers the peritoneal organs in males and females, forms the roof of the pelvic spaces, and the floor is formed by the levator ani muscle. These spaces are known as retroperitoneal spaces, and they are classified that they are bilateral or unilateral midline spaces. The bilateral spaces are pararectal spaces, which are on both sides of the rectum here, and the paravesical spaces. The midline spaces are prevesical space, the vesicovaginal or vesicocervical space, then the rectovaginal space and the retrorectal space. This photograph shows clearly the different prevesical space here, and can see the vesicovaginal space here, then the rectovaginal space is here, and retrorectal space. The lateral pararectal spaces and the paravesical spaces, here is the rectum, this is the pararectal space, this is the bladder, this is the paravesical space. They are again divided by different structures, like the paravesical space is divided by the obliterated umbilical artery, which runs here like this, forms the medial pararectal space, paravesical space, and lateral paravesical space of Let's Goes, which is here. I'll show you in the detail in the next slides. Again, here the pararectal space is divided by the ureter here in the medial pararectal space and the lateral pararectal space of Let's Go space. This photograph shows clearly this the pararectal spaces here, the paravesical spaces in this area, and the ureter running here. Coming in detail slightly about the pararectal space. The pararectal space, here is the bladder. You can see this is space which is formed, it's a retroperitoneal space lying lateral to the rectum, and the roof of the pararectal space is formed by the posterior leaf of broad ligament in females and the peritoneum in males. Its medial borders is formed by the internal iliac artery, and cranially this space terminates at the uterine artery. Cranially, it is caudal to the uterine artery, and the levator ani forms the floor of this pararectal space. The ureter, as I told you, divides this pararectal space into the two spaces, the medial to the ureter, the medial pararectal space, and lateral to the ureter, lateral pararectal space. There are two approaches described to access these two spaces of pararectal space. The one is the medial approach, another is the lateral approach. So what is the medial approach? The medial approach that is described is that this is the infundibulopelvic ligament. When you cut medial to the inferior ligament, the peritoneum here, then you see that first structure you're going to see will be the ureter here. So ureter will, when you go lateral to make the space lateral to the ureter, you will find the uterine artery, and this is the lateral pararectal space. And if you go medial to the ureter, it will be the middle part of the pararectal space. This is the lateral approach, which shows the incision on the peritoneum is made on the lateral to the infundibulopelvic. This is infundibulopelvic ligament. You make incision here, the lateral to the infundibulopelvic ligament. The first structure you want to visible is the external iliac artery. This is the external iliac artery here, and this area is the best for lymph node dissection, because when you cut it here and retract the external iliac artery and vein there, you go into the operator fossa here, and you can do the operator lymph node dissection. And this lateral approach also helps in easily opening the lateral paravesical space anteriorly. This is the photograph of the paravesical space. You can see this is the bladder here, which has got the lateral to the bladder, this retroperitoneal space, which is lying lateral to the bladder here, and it is enclosed medially by the bladder and laterally by the pelvic wall, pelvic side wall, and inferiorly by the uterine artery. So this paravesical space is superior and anterior to the pararectal space. Dissection of these spaces are easy to complete removal of the uterus and its attachment in radical hysterectomy. We have to really define these spaces when we do a radical hysterectomy. And this space, as I told you, divided in the medial and lateral paravesical spaces by the obliterated hypogastric artery, which is the branch of the internal terminal branch of the internal iliac artery. The medial paravesical space dissection is performed.
Pelvic anatomy with lecture है, webinar है, pelvic anatomy.
Hello. Am I audible?
Yes.
Hello.
एक
Hello.
वेबिनार चल रहा है पेल्विक एनाटॉमी, डॉक्टर नितिन कोटेटा है और पहले मावी जैसे में थे, अगर इंटरेस्ट हो तो pelvic anatomy, surgical anatomy of pelvis.
Speaking from behind, can you be close? Actually, Dr. Nitin, please continue with your session.
Yeah, thank you, sir, thank you. So, talking about the paravesical space as I was discussing, and the importance of defining the medial and lateral paravesical space. The medial paravesical space is that when we do an oncological resection for bladder cancer or radical hysterectomy, this space really has to be defined to go in a correct plane and a bloodless plane. And when in cases of cesarean section, when the uterus is adherent to the vesicle, this space has to be really opened up, and then the plane has to be made between the adhered uterus and the bladder to go in a proper plane. And pelvic exenterative surgeries also, we have to define this place clearly. The lateral paravesical space, which is not shown here in this photograph, but this is lateral to the obturator umbilical artery, and it is between the obturator umbilical artery and lateral pelvic wall, and which is full of lymph nodes. And in cancer patients, when we do a pelvic lymph node dissection, we have to define this space clearly and remove the lymph nodes which are superficial to the obturator nerve completely from the obturator umbilical artery to the lateral pelvic wall, anteriorly, inferiorly up to the inferior epigastric artery or corona mortis that I discussed, and superiorly to the level of the common iliac artery. This is the importance of lateral paravesical space, posterior dissection. And if the lymph nodes are enlarged in the superficial obturator fossa, then we have to go posterior to the obturator nerve and remove the lymph nodes posterior to the obturator nerve also to complete the oncologically sound lymph node dissection. The prevesical space is also known as space of Regius, which is seen in this photograph clearly. In the lower photograph, you can see this is the prevesical space, also known as space of Regius, and it communicates with the paravesical space here clearly. And the prevesical space is primarily exposed when you want to do surgery related to the bladder neck and the urethra, making it more significant for the management of stress, urinary incontinence, and sling surgeries. It is also useful when we are doing a radical hysterectomy. This space we have to enter when we do an exenterative, anterior exenterative or complete exenterative surgeries in our oncological cases. Coming very important to the rectouterine or rectovaginal space. This space we can say is upper lined by a peritoneal cavity, and this is known as pouch of Douglas. This pouch of Douglas anteriorly we can say is by the upper part of the fornix of vagina and the uterus, and posteriorly this pouch of Douglas is lined by the rectum. You can see this here, and this continues. It doesn't continue out. It is a cul-de-sac. It continues as a muscular fibromuscular tissue down, known as denovenous fascia. In males, it is known as puboprostatic fascia also. It is enclosed anteriorly, as I discussed, and the roof comprises the peritoneal. This is the roof which is formed by the peritoneal deflection. Floor is formed by the levator ani muscle here. And the rectovaginal space dissection is done until the levator ani is reached. And when we do it for EPR dissection or low anterior dissection or anterior exenterative surgeries, we have to go in this space and define these structures. It also helps in symmetric dissection of the vagina anteriorly as well as posteriorly. This photographs clearly, as I showed you clearly, this blue line is the peritoneum covering forming the pouch of Douglas here. And this is the denalvenous fascia. We'll discuss further. The denalvenous fascia runs between, we can say, is between potential areolar tissue, which is between the posterior vaginal wall and the rectum, clearly goes up to the pelvic floor. And the vaginal veins are present underneath the denalvenous fascia, hence the avascular pain is created exactly between the two layers. If we go anteriorly, there will be a lot of bleeding, so this pain has to be
Dr. Nitin, just hold for a second. Avinash, Dr. Avinash, can you mute somebody speaking from some side? It is interfering with the audio presentation of Dr. Nitin Khunteta. Can you mute him?
Vineet sir. Vineet sir.
Yeah, it's fine. You can continue, Dr. Nitin.
Yeah. So we're discussing about the Denner-Villiers fascia. It's a two-layered fascia which is present between, as I told you, present retroperitoneally between the rectum, anterior wall, and the vaginal, posterior vaginal wall. Is a potential space which is created for these surgeries. Yeah, in the males, here you can see this is the cul-de-sac, the pouch of Douglas, you can say the rectovesical pouch, and here from between the prostate and the anterior rectal wall, this is the Denner-Villiers fascia. It has to be clearly, defined during radical prostatectomies, radical cystectomies for bladder surgery, anterior sections. This plane is beautifully opened up to the pelvic floor, and the dissection is done. Coming to the retrorectal or presacral space is covered by the mesorectum anteriorly and the Waldes fascia, which covers the sacrum posteriorly. And posterior to the Waldesia fascia, there is a complex anastomosis of the veins here, which are the pre-sacral veins, which bleeds torrentially if you go in wrong plane during dissection, APR or anterior section or exenterative surgery. If you enter wrongly in the posterior to the prevesical fascia here, pre-sacral fascia here, then there will always be a torrential bleeding, because there's a network of venous system which is formed by the middle sacral vein and the lateral sacral vein, which are branches of the iliac veins here. Right. The retroperitoneal space, this retroperitoneal space, the presacral space, is important for us to know, because it is used and dissected out in posterior exenterative surgeries and abdominoperineal dissections and anterior section of complete mesocolic excision of involved rectum. It is also useful in deep infiltrating endometriosis involving the rectum, sacrocolpoplexy, and the presacral neurectomy. So this is a potential space, which is a retrorectal space. It's clearly opened up when we make a cut on the mesocolon and retract the rectum anteriorly. This space, this retrorectal space opens up easily in open surgery as well as in laparoscopic surgery. But never try to go posterior to the fascia, which is covering the sacrum, because if you go posterior to that in a wrong plane, massive bleeding will be there, and it will be difficult for us to control that area bleeding. Yabuki space, which is described, this is not lined by a peritoneal or epithelial lining. It is a midline small retroperitoneal space which is confined within the anterior surface of the uterus. We can see it here, and the ureter inserting into the bladder. This space is lined by the cervicovesical fascia. This is the cervical vesical fascia, and the cervical vesical fascia has the anterior part and the posterior part. Here lies the parasympathetic or inferior hypogastric nerves. Damage here to this parasympathetic nerve here will lead to bladder atony and the bladder morbidity in radical hysterectomy or exenterative surgeries. So this structure has to always be saved unless it is definitely involved by the tumor in cancer surgeries. As I told you, and the posterior part of the fascia wraps around, leaf around the communicates with the endopelvic fascia here along the uterosacral. So this is about the importance of the Yabuki space, which has to be defined for radical hysterectomy and when we do a radical cystectomy or prostatectomy in this area. Thank you very much.
Thank you. Thank you. Anatomy of the pelvis. So before I open the discussion to other participants, I just have one question. So in rectal cancer, actually, most Japanese groups, they do pelvic lateral lymph node dissection, but most groups in the West, and I think most groups in India also don't do it. So, but I suppose that in gynecological and urological malignancies, would you do a full complete lateral pelvic lymph node dissection? And if yes, what is the extent of that dissection?
Sir, in gynecological surgery, especially, we talk around when we do a operator fossa dissection, that is very important. The lymph nodes along the parametria or the Meckernots ligament, which is lying there, which are the first equivalent nodes for the cervical and endometrial cancers if they go there. And the pelvic operator pelvic lymph node dissection that we do is anterior. The boundaries are anteriorly the genitofemoral nerve, posteriorly the operator nerve, superiorly it is the common iliac lower part and its bifurcation, and inferiorly up to the inguinal ligament or circumferential iliac artery or the corona mortis. This is the defining part. If there are nodes in the operator fossa anterior to the operator nerve, then we do dissection posteriorly also. The extended dissection that is described in books like the technique which is described by Hochul also for radical hysterectomy, total mesometrial resection. The three groups of lymph nodes which are not dissected in this has to be dissected, which are the presacral lymph nodes, and there are some nodes which are medial to the common iliacs that are not dissected, has to be dissected. These two groups are also dissected in extensive radical surgery, sir.
And all these lymph node dissections will be nerve sparing.
Yes, sir, that depends on if the nerves are involved, the disease has come outside the organ and the nerve plexus is involved on that side, that has to be dissected along with that to make it an oncological sound surgery.
Any of the online participants? I think there are people from
Dr. Nahata wants.
Yeah, Dr. Nahata, please.
Sir, it was a very nice and thorough presentation about the pelvic anatomy. We wanted to be physically, but somehow could not come. But enjoyed the presentation thoroughly.
Thank you, sir.
I think we have colleagues from gynecology also.
Yes.
Would anybody like to make any comment?
Yes, sir. I Dr. Chandrakanta here, and it's very good presentation. I really enjoyed it. Thank you, sir.
Thank you, madam.
Thank you, sir.
Hello, Nitin sir. Am I audible?
Yeah, just wait a minute, please.
That was in young males that used to cause so that comes from the inferior hypogastric.
Inferior hypogastric is part of yes, sir. Which gives the parasympathetic system to the external the bulbous control.
Yes,
sir.
Yes, please
Yes, sir.
ask your question.
Yes, Nata sir, you want to ask something, sir? Okay. Yes, sir. Please speak, sir. Yeah, friend, sir, बताइए. Your voice is not audible clearly.
How do you
No, the sound is not clear, Dr. Fender. Can you just type the question or?
Am I audible now?
Yeah, definitely now.
Yes, fine. So what is your approach in cases of when you're targeting a sentinel lymph node? So which ICG, how do you inject? And at what time you open the lateral window? What are the precautions you take when you are targeting the sentinel lymph node in case of early cervical cancer, or you can say endometrial cancer?
We have a few experience of few cases in endometrial cancer where we inject the dye into the cervix at the level of 3 o'clock position and 6 o'clock position and 12 o'clock position and 9 o'clock position. And from that, when we start opening the abdominal cavity, we start defining these structures, and then we find these lymph nodes which are at the parametrium or Mechanodes ligament. These lymph nodes lighten up when we do the surgery, and then gradually over the next 20 minutes is go to the different lymphatics in the obturator fossa. So these firsticular nodes that we identify within 25 to 30 minutes time, we just pull out these lymph nodes for frozen section, and if they are positive, we go further for the dissection. This is the principle for doing a pelvic lymph node dissection with the help of ICG, sir.
So you keep the abdomen open, and then before opening the peritoneal cavity, the retroperitoneal space, that time you inject ICG in the cervix at 3 o'clock and 6 o'clock.
Yes, sir.
And then you use your gamma cameras or infrared.
ICG indigo cyanide green is clear. The camera system is there. We can see it clearly there. There's no need for a gamma camera. We are not using any nuclear dye here. So it is seen clearly there. The blue, you can see a clear blue greenish node there, and there are different intensities there. We can identify these lymph nodes clearly. And the first nickel equivalent lymph nodes are identified to take it out and do a frozen section.
Okay. Thank you, sir.
Thank you.
Any other question or comment from any of the online participants?
Yes, Dr. Nitin.
Yes, sir. So morning, sir.
Morning, morning. One of the most important structures in the pelvis is the ureter.
Yes, sir.
And in re-surgery, pelvic surgery, which has had irradiation and everything, identification of the ureter becomes difficult at times.
Yes, sir.
And one of the methods is the ICG. The other method is where you could put a laser light in that and you can illuminate the ureter while doing the surgery and identify the ureter.
Yes, sir.
So there are various methods of identifying where the ureter lies and preservation of the ureter.
Yes, sir. When we do an ovarian cancer, when the pelvis is filled of the ovarian cancer tissue, we can catheterize also, sir, from the bladder, both sides of ureter when the pelvis is full of tumor, and identify the ureter during dissections.
Yes. And it is very important that you do not bare the ureter.
Yeah.
And always have a leash or a mesentery on the ureter,
Yes,
so
sir.
that later on it does not necrose.
So what happens, the ureter is covered by its own mesentery or loose alveolar tissue where the arterioles run over it. Clearly, it is seen. That level of damage is generally when we separate the uterine artery for type 2 radical hysterectomy. The uterine artery gives branches, one of the branches to the ureter also. At that site, we have to clearly identify that branch and ligate or coagulate it, separate it, and save the ureter in toto incompletely.
And as far as possible, avoid direct or nearby use of direct cautery there.
Yes, sir. Yes, sir.
Nitin sir, in obturator group of lymph node dissection, we usually keep ourselves above the obturator nerve.
Yes, sir.
So is there any particular indication where you go below the nerve and take out?
Sir, if you find that the posterior part of the obturator fossa, that is posterior to the obturator nerve, there are lymph nodes. In that case, only you have to go and pull out these lymph nodes for radicality. Otherwise, there is no need, sir.
Thank you, sir.
Thank you.
Any other question or comment? Otherwise, we will close the session. So I would like to thank Dr. Nitin once again for making this presentation, which was useful not only to our department, but several other specialties also. And thank you all the senior colleagues from other departments for attending. Thank you. Thank you, Avinash. Thank you very much.
Thank you, sir. Thank you very much, sir.
Thank you, sir. Thank you.
Thank you, sir.